What I'll try to do in the next few minutes is to really address in a very compressed way several topics regarding antithrombotic therapy, and particularly a combination of antithrombotic and antiplatelet agents and various iterations of combinations of antiplatelet agents, and to give a perspective of what the totality of the trial and the data suggests, maybe not always what we're doing, but probably what we should be doing. And finally, to try to look at perspectives for the future of where this field might be going, particularly with atherosclerotic cardiovascular disease prevention, both in the primary and secondary prevention settings. These are my disclosures. So let me start with a simple topic, the duration of antiplatelet therapy after PCI and ACS. There's been an incredible amount of trial and studies looking at this, and so many iterations and combinations of strategies that can be used to manage antiplatelet therapy after PCI or ACS. And I would like to make this as simple as possible, and I believe it is actually quite simple. It starts with guidelines which generally have recommended a duration of 12 months of dual antiplatelet therapy after PCI or ACS. And this is true for the European guidelines. I could share the American guidelines, I could share the Canadian guidelines, the British guidelines, the Australian guidelines. They all recommend 12 months of duration of antiplatelet therapy. And interestingly enough, it's been pointed out that there was really no formal test of that conventional 12 months duration of dual antiplatelet therapy. If you look at the 3 original large-scale trials that have led to the recommendation that are often quoted, the CURE trial, the TRIDENT trial, and the PLATO trial, neither of them formally tested duration. They tested various combinations. And interestingly enough, the median duration of DAPT in all of these trials was never 12 months. So the 12 months really comes out of the blue. There's really no strong data to support the idea that 12 months should be the default duration of dual antiplatelet therapy. Now, there have been a myriad trials looking at various durations of dual antiplatelet therapy, and they've been recently reviewed by Marco Valgimigli in Circulation, and they can be summarized in this slide, and the message is very simple. If you try to use shorter durations overall across the board compared to longer duration of 12 months, there's really no difference in the most outcomes except for major bleeding, which is totally expected. A shorter duration of dual antiplatelet therapy will lead to less bleeding. I'm not sure we should be applying the evidence that way, as you'll see in a minute, because what really drives everything seems to be the bleeding risk. And there are a myriad ways to assess, again, bleeding risk. There are various bleeding risk scores that are around. The latest iteration was published very recently in Circulation. It's actually in advanced publication on the Circulation website. It's the precise HBR bleeding risk score, which seems to outperform most of the other bleeding risk scores, and it's based, as unsurprisingly, on very standard items: age, prior bleeding, hemoglobin, eGFR, white blood cell count, use of oral anticoagulants, and various items from the ARC-HBR criteria. And as you can see, if you rank patients as a function of their HBR bleeding risk score, well, their actual risk of bleeding is very, very different. How can we put this to use to decide in whom to shorten and in whom not to shorten antiplatelet therapy duration? Well, Marco Valgimigli, in his recent Circulation review, has done this stratification, which is really interesting, looking at longer versus shorter DAPT stratified by high bleeding risk. And you can see the impact it has on bleeding events on the top, on ischemic events in the middle, and on net adverse events, which is the combination of ischemic and bleeding events at the bottom. And if we start with high bleeding risk patients, as expected, high bleeding risk patients appear to favor short DAPT because that leads to benefit in reducing bleeding, without any clear difference on ischemic events, such that the net adverse clinical events are very favorable for shorter DAPT in high bleeding risk patients. Conversely, and I think that's also interesting and often not quoted, in patients who are not at high bleeding risk, there's really no difference in bleeding whether you use short versus long DAPT, but there's a dramatic difference in ischemic events such that net adverse clinical events appear to favor longer DAPT in patients who are not at bleeding risk. So it's really your bleeding risk that decides and drives and should drive the duration of dual antiplatelet therapy. And that's been tested subsequently in large trials, such as the MASTER DAPT, in which abbreviated DAPT did reduce bleeding risk without increasing MACE in patients who were selected at entry for having a high bleeding risk. And I could say the flip side of this is really the analyses that were done from the THEMIS and THEMIS PCI trials that I had the privilege to conduct with Dr. Bott, in which diabetic patients with stable CAD not at high bleeding risk derived greater benefit from prolonged and protracted dual antiplatelet therapy with aspirin and ticagrelor compared to aspirin alone. So the message for duration of antiplatelet therapy after PCR or ACS is shorten for high bleeding risk patients and do not shorten for patients who are not at high bleeding risk. Another question is, what should we do long-term for these patients when we want to shorten? Should we go to aspirin after that, or should we go to P2Y12 monotherapy? Well, with advances in antiplatelet therapy, we've kept adding treatments to aspirin. We started with ticlopidine, and then prasugrel, and then ticagrelor, and then ticlopidine, then clopidogrel, then prasugrel, then ticagrelor. But maybe the foundation should not be aspirin. Maybe the foundation should be a P2Y12 inhibitor, and maybe we could do away with the aspirin. And that's been tested in a series of trials, and certainly one of the most interesting and well-done trials was the Twilight trial conducted by Dr. Maron, which was one of the very few trials that was placebo-controlled in a double-blind manner. And in that Twilight trial, patients who were even free 3 months post-PCI were randomly assigned to aspirin or placebo on top of ticagrelor, everybody being on ticagrelor. And as you can see, ticagrelor plus placebo did better in reducing bleeding compared to DAPT, with no effect on ischemic events on the right. So no price to pay for that reduction in bleeding. And that was true across the board in this trial, including in diabetic patients, including in patients who were post-ACS. So it seems that ticagrelor monotherapy 3 months post-PCI is a remarkable strategy and a very attractive strategy. That was not the only observation going that way. There were subsequent trials that went the same way. Global leaders, Smart Choice, Stop DAPT2, TICO, they've been pulled in this meta-analysis by Michelle O'Donoghue, showing again really a clear reduction in bleeding and no signal of harm in terms of preventing MACE. In fact, if anything, MACE appears to be trending favoring monotherapy with ticagrelor. And then of these trials, there was an extraction that was done of the trials that specifically looked at ticagrelor monotherapy rather than P2Y12 monotherapy. And that's again been published by Marco Valgemigli in The Lancet. As you can see, Dr. Valgemigli has been remarkably productive in this space. And what the meta-analysis shows is that there's, again, as would be expected, great benefit of using ticagrelor monotherapy compared to DAPT after PCI in reducing bleeding, regardless of how you measure bleeding, whether you look at BARC type 2, 3, 5, type 3 or 5, or net adverse clinical events, bleeding plus the MACE. For MACE, there's really no difference. And for all-cause mortality, there's a signal favoring ticagrelor monotherapy, actually borderline statistically significant for ticagrelor monotherapy, again indicating that this is quite an attractive strategy. So I think that we should consider that maybe we can solve all of these problems about DAPT and DAPT duration and which strategy should we use by using as a default strategy ticagrelor monotherapy after 1 to 3 months post-PCI or ACS. Now, what about the very long-term strategy? Which monotherapy should we use long-term for preventive purposes in patients who have established coronary artery disease? Traditionally, it's been aspirin. And we know that aspirin is cheap, and it is quite effective as a cheap intervention, but it's not perfect. Do we get better results if we substitute a P2Y12 inhibitor for aspirin? Well, more recently, a provocative trial came out from Korea, the HOST exam trial, which looked at aspirin versus clopidogrel for chronic maintenance monotherapy. And as you can see here, in that trial, the surprise was that actually clopidogrel appeared to outperform aspirin everywhere. It outperformed aspirin for ischemic events prevention at the bottom left. It outperformed aspirin for bleeding on the right part of the slide. And if you combine ischemic and bleeding events into net adverse clinical events, then there was massive benefit of clopidogrel over aspirin for chronic maintenance monotherapy. This prompted us to go back with several investigators, including Dr. Butt and Dr. Valgemigli, and the Panther pooled analysis looking at individual patient-level data from all the trials that had looked at P2Y12 monotherapy versus aspirin in stable coronary artery disease. And this came out in JACC last year, and again, shows that P2Y12 monotherapy outperforms aspirin for ischemic events on the left and for bleeding events on the right. Not statistically significantly so for bleeding, but certainly for ischemic events, it is statistically significant. So really, there's very little reason to continue to use aspirin as our default strategy now that clopidogrel has gone generic and has become much cheaper than it was in the past. So I don't think this is well realized by most people, and I don't think it's become yet the default strategy in most places. But the data actually points to P2Y12 inhibitor monotherapy over aspirin therapy for chronic maintenance antiplatelet therapy in patients with coronary artery disease. Another slightly different but somewhat related question is, what do we do in patients who have coronary artery disease who require long-term oral anticoagulation? Should we insist on adding aspirin or antiplatelet monotherapy to oral anticoagulation, or can we do away with the antiplatelet therapy and use oral anticoagulation alone? So the data we have is interesting because we have 3 trials, and I don't think we have a very, very clear answer yet. The first 2 trials have been published a while ago in 2019. Both were halted prematurely, and they're quite small. The first one was the OAC alone trial that suggested that OAC plus SAPT appeared to outperform OAC alone, but that was not statistically significant. The subsequent AFIRE trial done in Japan found the reverse, found that OAC alone was superior to OAC plus aspirin in preventing ischemic events and led to reduced bleeding. This year, the EPIC CAD trial was presented and just published in the New England Journal of Medicine, comparing edoxaban monotherapy to dual antithrombotic therapy, and there was no significant difference in terms of ischemic events on the top, but there was a clear reduction in bleeding with edoxaban monotherapy compared to dual antithrombotic therapy. I think it's important to remember that all of these 3 trials had a very limited number of events, a small number of patients, but even smaller number of events, and they were all open label, which of course can be problematic in the assessment of these antithrombotic strategies given crossovers and so on. There's a 4th trial that I happen to be associated with, which is done in France, which is a nationwide trial called Aquatic. And the Aquatic trial is looking at all AF patients on oral anticoagulation therapy, whether or not they were on antiplatelet therapy plus single antiplatelet therapy, who have a history of stent implantation of more than 12 months ago. And they're randomized to aspirin or placebo in a double-blind manner, being stratified on whether they were on OAC alone to start with, or on OAC plus SAPT, i.e. were they naive to antiplatelet therapy or not at the time of randomization. And that trial has concluded enrollment and will be presented in the next few months, and I hope it will help provide a definitive answer. We've already agreed with the investigators of the other 3 trials to do a pooled individual patient-level meta-analysis of the data. So the answer is we probably not need to add aspirin to CAD patients, but if you look at the confidence intervals for the ischemic events, they're quite wide, which I think explains why we need to wait for the results of the Aquatic ongoing trial. Finally, if we get now to anticoagulation, anticoagulation has made tremendous progress over the past decades. The factor 10 inhibitors and the direct thrombin inhibitors have been major advances in the space, but they have not been used in all the patients who require them, particularly because of the fear of bleeding. And we continue to experience substantial rates of bleedings in these patients. So these treatments are effective, but they're not as safe as we would like them to be. Can we have safer anticoagulants? Well, there's theoretical reason to believe that this may be true. And the reason this may be true is that maybe instead of inhibiting factor 2, thrombin, or factor 10, or activated factor 10, we could achieve safer anticoagulation by inhibiting factor 11. And the reason for this is that factor 11 is dispensable for hemostasis. Hemostasis is what prevents us from bleeding when we cut our finger with an envelope. You know, we generally don't die from bleeding when we cut our fingers from an envelope because there'll be a platelet clot and there'll be a fibrin clot related to this hemostasis process, which is really from outside in injury, in which factor 11 actually is dispensable and the extrinsic pathway is activated by tissue factor, factor 7, factor 10, and thrombin generation, and quickly produces a clot that will save us from bleeding. Conversely, bad thrombosis, bad clots, are related to thrombosis, which is an inside-out process in which plaque disruption or activated leukocytes or microvesicles will release tissue factor, which will generate factor 7 activation and factor 10 activation, which then will undergo a massive amplification loop that involves the intrinsic pathway and factor 11. So factor 11 plays a key role in clotting, but not in hemostasis. And that generates the hypothesis that maybe inhibiting factor 11 instead of the other steps in the coagulation cascade may allow to uncouple hemostasis and thrombosis and thus provide safer anticoagulation. And interestingly enough, we have pretty strong animal data and genetic data to back this up. I won't bore you with a review of the factor 11 evidence, but let's just share this slide, which is an animal model of thrombosis on the left, in which there was a comparison of dabigatran and apixaban in red and green, and a factor 11 antagonist in blue. And as you can see, as you increase the doses of these various anticoagulants, you restore flow in this carotid blood flow model. And there seems to be similar antithrombotic efficacy between factor 11 inhibition, factor 10 inhibition with apixaban, or direct thrombin inhibition with dabigatran. In the right side of this slide, you now have a bleeding risk model, an animal bleeding model, kidney bleeding time, in which you look at the increase in bleeding that's dose-related for dabigatran in red, for apixaban in green, but absolutely a flat dose response curve for the factor 11 antagonist. As you increase the dose, you don't get increased bleeding. And that suggests that there may be a window where you're able to inhibit thrombosis and not generate bleeding. These factor 11 antagonists have so far mostly been tested, in fact, in phase 2 studies. There have been a few small dose-ranging studies done in orthopedic surgery, largely as dose-ranging and dose-finding studies. One of them was the axiomatic TKR study with milvexian, one of the oral factor 11 antagonists, in which milvexian at various doses was compared to the standard of care, which was deemed to be enoxaparin. As you can see, as you increase the doses of milvexian, whether you use it once daily or even better, twice daily, you're able to get rid of venous thromboembolism in a much more effective way than with enoxaparin and with less bleeding than with enoxaparin. And when you do an exposure response analysis, I think this is quite an interesting analysis from this same trial, you can see on the left the plotting of the risk of venous thromboembolism compared to the concentration of the drug in the x-axis. And as you increase the dose, the risk of VTE decreases dramatically. On the right, if you look at the probability of bleeding as a function of dose and exposure, actually the curve is quite flat. Again, confirming in humans what's been reported in animals, in the animal models I've just shared. Now, this year, the Oceanic AF trial, which was a comparison of asundexian, a factor 11 antagonist, to apixaban in atrial fibrillation for stroke prevention, was halted prematurely, and the results were just presented at the ESC in London and subsequently published in the New England Journal of Medicine. And what you may have heard is that in that trial, apixaban appeared to clearly outperform asundexian. Even though the rates of stroke and systemic embolism were low, 0.4% and 1.3%, there was a dramatic and statistically significant difference in favor of apixaban that led to premature termination of the trial. So that trial has been stopped. There's another trial with the same compound, asundexian, that is going on, which is not comparing asundexian to apixaban, to full-dose anticoagulation, but to placebo on top of dual antiplatelet therapy in patients with recent ischemic stroke. And that trial, with the same DSMB as the Oceanic AF trial, is going forward. And I suspect the reason this trial is going forward is that probably the dose of asundexian that was used in the atrial fibrillation trial was a little on the low side compared to what is being tested with other similar agents in the same setting. There's another large-scale clinical trial program of factor XI antagonists going forward with milvexian, the other oral factor XI antagonist, with 3 trials, one in atrial fibrillation, one in secondary stroke prevention, and one in ACS. And of note, the dose of asundexian that was used in Oceanic AF was 50 milligrams QD. The dose of milvexian that is used in Librexia AF compared to the same comparator of apixaban 5 milligrams BID is 100 milligrams BID, 4 times higher dose than in the Oceanic AF trial. And I think that this points out to the differences in dosing that may be critical to the success of preventing ischemic events and thromboembolic events in these trials. It's one thing to be safe, but if you're not effective, if you use too low a dose that is ineffective, of course, that cannot go forward. So can we have safer but effective anticoagulants? I don't think we have an answer yet. Factor XI antagonists are being tested. One trial has been stopped. There are many other trials that are going forward. I think we'll get an answer starting in 2026. Finally, can we achieve safe dual pathway inhibition in CAD? And why would we want to achieve safe dual pathway inhibition? Because as I started off, dual antiplatelet therapy has been the mainstay of antithrombotic therapy in patients post-ACS and post-stenting. But we know that thrombin generation exists in these patients and is actually increased compared to the normal levels despite dual antiplatelet therapy, because of course dual antiplatelet therapy does not directly affect thrombin generation. And we know that this increased thrombin generation persists over time for at least 6 months to a year. There have been many trials that have tried to combine anticoagulants with antiplatelet therapy starting in the last century. For instance, the WARIS-2 trial in the pre-clopidogrel era tested aspirin plus warfarin compared to warfarin alone and aspirin alone. And if you look at sheer efficacy, well, actually, the combination therapy was the best. There was a lower rate of event in warfarin plus aspirin compared to warfarin alone or aspirin alone. The problem, of course, is that there was an acceptable bleeding. It was very inconvenient to use warfarin plus aspirin. Subsequent attempts to do this using factor X antagonist with, for instance, rivaroxaban, were also interesting. In the ATLAS trial, actually, rivaroxaban, very low dose, added to antiplatelet therapy appeared to outperform placebo or a higher dose of rivaroxaban. But again, there was an increase in bleeding. But if you look at those patients who had clear myocardial infarction with elevated cardiobiomarkers and no prior stroke or TIA, which is a post-hoc subgroup of the ATLAS trial, there was not only a reduction in CVS-MI stroke, but there was actually a reduction in cardiovascular mortality and all-cause mortality, suggesting that this is really a strategy that we should be looking at very carefully. Closer to us, the COMPASS trial looked at low-dose rivaroxaban versus rivaroxaban plus aspirin or aspirin alone in patients with stable atherosclerotic vascular disease, coronary artery disease or peripheral arterial disease. And many of you in this room, including Dr. Bat, have been intimately involved in this trial. And as you remember, this trial was prematurely terminated for overwhelming efficacy by the DSMB and the steering committee because the rivaroxaban plus aspirin arm came out on top, reducing more effectively these risks. There was even a lower mortality in the rivaroxaban plus aspirin arm compared to aspirin alone, although it didn't reach the pre-specified threshold of 0.0025 related to the alpha sparing strategy for that trial. It was 0.82 with a p-value of 0.01. So certainly an interesting signal of lower mortality. But again, in COMPASS and in other trials, there was a price to pay for the efficacy, which was increased bleeding. And I think that has largely contributed to prevent the widespread adoption of this dual pathway strategy. And I think that now that we're testing anticoagulants that we hope are as effective and safer than conventional anticoagulants, the factor XI antagonists, it's going to be really tantalizing to see whether we can combine factor XI antagonists to antiplatelet therapy strategies post-ACS. And there's a a large ongoing trial called Librexia ACS. Again, Dr. Bat and I are involved in this trial. It's comparing milvexian to placebo on top of any background dual antiplatelet strategy that's deemed desirable by the investigators in ACS patients post-revascularization. Enrollment is going fast, and we're hoping to conclude the trial and provide results by 2026. So to summarize, well, we have some answers. Duration of antiplatelet therapy after PCI or ACS should be shortened in patients with HBR and longer in patients who are not at bleeding risk. Ticagrelor monotherapy after 1 to 3 months post-PCI is a very attractive strategy, although it's not caught yet a large span of the market, if I may say. I think it's actually very attractive, and the data pleads for that. Long-term antiplatelet therapy in CAD, we should consider P2Y12 inhibitor monotherapy over aspirin, given the data that's available. We probably do not need to combine aspirin with oral anticoagulation in patients who have CAD and have long-term anticoagulation, but it's going to be important to look at the results of Aquatic coming up in the next few months. We may have safer but effective anticoagulants with factor XI antagonists, but that's a promise. We'll see whether it's kept. And finally, it might be possible, if the factor XI antagonists are effective, to achieve safer dual pathway inhibition in CAD. Librexia ACS will provide the answer. I'll stop here, and I'll be delighted to take questions. Thank you.